Hi, I'm Dr. Hyun Choi at Massachusetts General Hospital. In this presentation, we'll go over the key points of the treat-to-target serum urate strategy in gout care, focusing on our TRUST trial's operational specifics. As you might remember, this gout pathogenesis slide included in the review done by Dr. Yokose. This treat-to-target serum urate, abbreviated as a TTT-SU, is based on the known key pathogenetic factor of gout, chronic hyperuricemia, which leads to monosodium urate crystallization, which is abbreviated as MSU, and a tissue deposition of crystals, eventually leading to recurrent gout flares and chronic arthritis with crystal burden sequelae such as tophus deposition. As such, by lowering serum urate levels below the saturation threshold, which is approximately 6.85 milligram per deciliter, we can prevent and reverse these processes. So our usual serum urate target is less than 6 milligram per deciliter, which allows for the dissolution of existing crystals and prevent new crystals from depositing. Then over time, this process can effectively cure gout, quote unquote. However, this process in the short term can be associated with paradoxical gout flares, which refer to increased risk of gout flares during initiation of urate lowering therapy. For this reason, gout flare prophylaxis is recommended during this period, which will be reviewed in another video. TTT-SU strategy is recommended by rheumatology specialty guidelines, including those from American College of Rheumatology. The first line of urate lowering therapy is xanthine oxidase inhibitors, with allopurinol as the preferred choice, followed by febuxostat. Probenecid and pegloticase are also employed in gout care practices, although infrequently, and they are not included in the TRUST care protocol. Allopurinol, as the preferred first-line urate lowering therapy, is dosed once daily, starting at 100 milligrams. The dose will be up-titrated based on serum urate response to achieve serum urate target of less than 6 milligram per deciliter. And the max dose will be 800 milligrams daily. The dose titration schedule is displayed in this table. If serum urate target is achieved at a given dose, we stop escalation and continue that dose for the rest of the trial. If not achieved, the titration continues up to 800 milligrams daily by week 28. Allopurinol is generally very safe and well tolerated. 2 to 3% may experience mild skin rashes and rarely liver enzyme abnormalities. Very rare but serious side effect is allopurinol hypersensitivity syndrome, abbreviated here as AHS, which can include severe skin and mucosal adverse effects such as Stevens-Johnson syndrome and toxic epidermal necrolysis. HLA-B5801 genetic marker has been identified as a key risk factor for AHS and exists frequently in Asians, except for Japanese, Blacks, and Native Hawaiian and Pacific Island descents. We screen all such patients with a blood test, and if positive, we avoid allopurinol and use febuxostat instead. Febuxostat is a second-line urate lowering therapy, again dosed daily starting at 40 milligrams. The dose will be up titrated to 80 milligrams daily if serum urate after 4 weeks remains above target under the same TTT-SU principle. If the target serum urate is achieved, continue that dose, same as the allopurinol dosing strategy. The maximum dose allowed in the trust will be 80 milligrams daily. The febuxostat dose titration schedule is displayed in this table. Simpler than the allopurinol dosing, as it involves just one-time increase until it reaches its max dose allowed. Febuxostat is generally safe and well tolerated with common side effects similar to those of allopurinol, but it is not associated with severe cutaneous reactions. As such, it is safe to use in patients who are HLA-B5801 positive. However, it carries controversial FDA black box warning for potential increased risk of cardiovascular adverse events with a conflicting study findings, including those from randomized trials. Nevertheless, this agent has been safely employed as a secondary option for recent trials analogous to our protocol. Thanks for watching the video, and this concludes TTT-SU review. And the detailed contents is provided in the nursing training manual as well as reading materials. Also, I'll be happy to reply to your additional queries you might have via email. Thanks again.